Yeah, Dr. Pavitra, you can start.
Respected all.
Dr. Sandhya, shall I start?
Yes, sir, we are starting.
No.
Yes, Dr. Pavitra will
Respected
first.
all, Vanakkam and Namaskar from Chennai, India. On behalf of Department of Pathology, Sri Ramachandra Institute of Higher Education and Research, we extend a warm welcome to all the participants across the countries. Not taking much of your time, let's dip ourselves into the ocean of knowledge. It has always been a honor for me to welcome Dr. Anandan Sir, Dean of Medical College, to give a short introduction about our institute. And Sir had always been a constant guiding spirit through our countless victories. Over to Dr. Anandan, sir.
Good morning, Dr. Raghavendra and registrants in USA. Good evening to the registrants, participants of this webinar from different parts of the world. Myself, Dr. Anandan, Dean and Professor of Dermatology at Sri Ramachandra Medical College and Research Institute. To give a small introduction about this great institution, Sri Ramachandra Medical College and Research Institute was started in the year 1985 by the eminent philanthropist, Mr. NPB Ramasamy Udiyar, in a village called Porur at that point of time. It was started as a unitary medical college. From there on, with 100 seats, in 1993-94, the Ramachandra Medical College was awarded the deemed university status by Human Resources Development Ministry, and the number of MBBS seats moved up from 100 to 150. By the way, the College of Physiotherapy and other faculties were started in the campus. Today, Sri Ramachandra Institute of Higher Education and Research, apart from Sri Ramachandra Medical College, boasts of nearly 13 other faculties like Faculty of Dental Sciences, Faculty of Pharmacy, Faculty of Nursing, and so on. The Department of Pathology has been doing outstanding work in the Division of Pathology for the past 35 years. And to say, Dr. Sandhya Sundaram, I should congratulate you for organizing the first webinar in Sri Ramachandra Institute of Education and Higher Education and Research. Whenever I say any webinar or any topic, the choice of topic is very important, and you have chosen the right topic, and more importantly, you have chosen a right speaker. Lung cancer is not an uncommon event in this part of the world, and to talk about histopathology of lung cancer, we have a very eminent doctor from USA, Dr. Raghavendra Pillappa, who is a staff physician and pulmonary thoracic pathologist, Division of Anatomic Pathology, Virginia Commonwealth University, Richmond, Virginia, USA. As the Dean of the Medical College, it gives me immense pleasure to welcome all the participants of this first webinar organized by Sri Ramachandra Medical College and Research Institute. And my proud privilege to welcome Dr. Raghavendra, who has consented to deliver this particular topic, role of histopathology in lung cancer. I wish all the participants have a wonderful webinar, and I'm sure, but more than 500 participants have registered for this event. I'm extremely happy and congratulate Dr. Sandhya Sundaram and members of the Department of Pathology for organizing this webinar. Let us go to Dr. Sandhya Sundaram. Please introduce Dr. Raghavendra. Wish everyone a great webinar time. Thank you.
A very good evening and welcome to this web evening at 6 a.m. on a very important topic. And I thank our Dean, Dr. Anandan sir, who has given a very beautiful introductory message and has encouraged us to host this webinar. Now, it's my proud privilege to introduce our speaker for the day, Dr. Raghavendra Pillappa, who is currently the staff physician and pulmonary and thoracic pathologist, Division of Anatomic Pathology at Virginia Commonwealth University, Richmond, USA. So, Dr. Raghavendra Pillappa is actually did his undergrad from URS Devraya Medical College at Kolar, India, and then he went on to do his pathology residency at King's, India. And then he flew to the USA and did his clinical pathology and anatomic pathology at University of Tennessee Health Science Center. And he has several academic appointments. He's a director of immunohistochemistry, Department of Anatomy Pathology at VCU. He's also the assistant dean of basic sciences at the International American University College of Medicine, St. Lucia. He's a course director, Department of Pathology at the same university. He has been awarded biennial abstract commendation of merit award by Pulmonary Pathology Society, Chicago. And he's an editor for the social media at the Archives of Pathology and Laboratory Medicine and ad hoc reviewer at American Journal of Clinical Pathology. He has several good publications to his credit and has also contributed chapter Radiation Pneumonitis in the Color Atlas and textbook of Pulmonary Pathology. I think we have a very young, expert, dynamic, ready to go. And thank you so much, Dr. Raghav, for accepting our invite on this very important topic, which has always foxed many a pathologist. Once again, I welcome you to this beautiful webinar, which will throw light on this very important topic. Over to Raghav. Raghav, the web is all yours.
Thank you very much. Thank you, Dr. Anandan, for your kind introduction and gracing the occasion. And Dr. Sandhya Sundaram, thank you for organizing this webinar and inviting me. And also thank you to Dr. Narsimhan, who is very instrumental in starting this webinar. And I'm honored and privileged to be part of this because this is the first webinar by you guys. So I'm very honored. Are you able to see my screen now? So if you're able to, I've shared my screen now. Can you able to see the PowerPoint slides now? All right, I'll get started.
We can see your PowerPoint. Yes.
Okay.
Please go.
And you can hear me also clear.
Yes.
Okay, very good. So welcome attendees, welcome to this webinar. So I'm the pulmonary pathologist from Virginia Commonwealth University, and I've been very privileged to give this webinar talk on role of histopathology in lung cancer. So today I'm not going to give you everything about lung cancer, but I'm going to talk some important entities and important challenges we face in our practice when we look at this lung cancer biopsies or we look at this resection specimen. So it could be any type of specimens, needle core biopsies or lung resections. So we need to understand some basic principles of lung cancer and the classification and the interpretation. So I have nothing to disclose as far as the financial disclosures are concerned. So this is my general outline. Diagnostic challenges during evaluation of lung cancer specimens. And again, briefly, I'm going to recap some new additions, even though 2015 WHO classification is an old one now because we are in 2020, but still I'm going to recap some of the newer additions during that time, which we still follow for lung adenocarcinomas. So much of my talk you can see would be revolving around lung adenocarcinomas because that's the one which has seen the most advances and updates in the recent past. And in between, I'm going to throw some few scenarios about challenges and we encounter when we are interpreting this lung cancer specimens. Briefly, I'm going to talk about some non-specific immunohistochemical profile. Again, most of our institutions, we do immunohistochemistry to specifically type the lung cancer. But sometimes when we are doing this immunohistochemistry stains, we end up with non-specific findings or kind of a confusing kind of findings. So I'm going to go through, touch upon those things so that we have some common ground rules such that we can come out of those and solve those challenges. And then there's been a recent talk about STAS, spread through air spaces, which is described as a fifth type of invasion in lung cancer. And there's also people have told that this is not a real phenomenon. It's just an artifactual kind of process, which is nothing but stacks that is spread through knife surface. So briefly, I'm going to touch upon between differences between those two. And also, I'm going to slightly talk on intraoperative evaluation of STAS as well. Means we all do frozen sections. So during frozen section, we are mostly restricted for two things. One is a diagnosis. If we already have, if we don't know the diagnosis on the specimen, we concentrate on diagnosing what we have given. The second thing is margins. That's what the surgeons are most interested during the frozen section. But uh, where do we stand on the STAS phenomenon during intraoperative consultations? So briefly, I'm going to touch upon that too. And then finally, I'm going to talk about molecular testing in lung cancer, especially lung adenocarcinomas and PDL1. So the PDL1, the immunotherapy has created a lot of ripples in the field of lung cancer, not just lung cancer, in various other cancers, melanomas, and it's spread every other cancer. You would see a lot of information about PDL1. So I'm going to just restrict my PDL1 information only to the lung cancer and more specifically how we interpret lung cancer specimens as far as the PDL1 immunohistochemistry is concerned. So that's going to be my outline. So means if you have any questions, you can obviously type in the chat box if that you can do that, or you can share it later. However that is possible. So I look forward to discussing these topics with you now. So first one is, yeah, obviously the role of histopathology in lung cancer, it's very important because pathology is the one which can differentiate adenocarcinoma from squamous cell carcinoma, or even small cell carcinoma from non-small cell carcinoma. So unless you see the tissue under microscope, you will not be able to tell the difference. Again, we have some rules for adenocarcinoma glandular differentiation on H&E slide. And then if any of you do immunohistochemical stains, so TDF1 and NAPCNA should be positive. And also the other thing is presence of targetable mutations, because previously there was, since a long time back, we know there were EGFR mutations, there KRAS mutations, but recently we have seen a lot more than that when we have increased the number of genes tested for this lung cancer specimens. For squamous cell carcinomas, it looks like any other squamous cell carcinoma in the body, in the rest of the body. That means in well-differentiated squamous cell carcinomas, you will see keratinization or intercellular bridges in moderately differentiated. In poorly differentiated squamous cell carcinoma, it's always a challenge because the poorly differentiated tumors, it can go either way, adenocarcinoma or squamous cell carcinoma. That's when the immunostains are helpful. And again, it's important to diagnose because it's not to treat with inappropriate drugs because that can lead to toxicities, which are difficult to treat in these patients. So this slide shows you this 2015 WHO classification of lung adenocarcinoma. Like I mentioned, my talk would be more concentrating on adenocarcinomas. So what are the entities which were discontinued from the previous classification? So those are bronchiolo-alveolar carcinoma, mixed subtype adenocarcinoma, clear and signet ring cell carcinoma. So these entities were discontinued. There were some new entities added instead of that. That's lipidic adenocarcinoma. Then the pre-invasive lesions like here, adenocarcinoma in situ, atypical adenomatous hyperplasia. So those two pre-invasive lesions were added. And then there was one more entity added, minimally invasive adenocarcinoma. And there was also another entity added, which is invasive mucinous adenocarcinoma, which I'm going to talk more on that. So if you look at this, adenocarcinoma in situ, atypical adenomatous hyperplasia, minimally invasive adenocarcinoma, and lipidic adenocarcinoma, the common histologic pattern is lipidic growth pattern. So that's our first challenge, identifying the lipidic growth pattern on histology. So formerly this was called as bronchiolo-alveolar carcinoma, but now that term is retired from the WHO classification. We don't no longer use it. So the challenge one is identifying lipidic growth pattern. The other patterns which are described in invasive adenocarcinomas are acinar, papillary solid, and micropapillary. Cribriform growth pattern is not in the WHO 2015. It's not yet included in the WHO 2015. So the invasive adenocarcinoma patterns comprises acinar, papillary solid, micropapillary. So I'm just showing a normal histology image of alveolated lung parenchyma. So you can see here, these alveolar spaces have got this thin alveolar septa, and each of these septa has got some flattened kind of epithelial cells, which are type 1 pneumocytes. And there are some plumpy ones, which are more cuboidal, but they're fewer in number. So these are type 2 pneumocytes. These are the ones which produce surfactant. But otherwise, if you notice, there's a single layer of capillaries, and you can see some red blood cells here too. So it is so thin, it's pristine, and it has got single layer of capillaries. So that's the architecture which we are looking for. And also there's some plumpier cells in the intraalveolar spaces, like here, you can see some of them has got this blackish kind of pigment. So these are macrophages. So these are resident cells of alveolated space. So you can find them in there too. Again, this is just an higher magnification showing the green arrows are pointing towards the type 1 pneumocytes, or the flattened cells or the simple squamous epithelium. And then the plumpy cells are the ones which are cuboidal cells, or the type 2 pneumocytes. So these are the type 2 pneumocytes. And then in between, you can see the capillary red blood cells. So in this picture, you can see that normalish looking alveolated parenchyma with normal alveolar spaces. And without disturbing of the architecture on the right side of the picture, you can see there is increased number of cells. But if you notice, these cells are just growing along the pre-existing alveolar spaces or alveolar septa. So this same septa, if you add in these cells, so that's what you see on the right side. And again, if you notice, many of these cells, as they're lining in a single layer, there are some gaps in between them. And again, very few places there's piling up of cells. Very few places there's piling up of cells. Otherwise, there's just single layer of cells. You can see some gaps in between. So this is what we call lipidic growth pattern. So how did the word lipidic came into existence? So it was invented by Dr. John George Adami, and it was first used in Toronto Pathological Society in 1902. And it was originally applied to tumors derived from surface lining cells. But in the Spencer's pathology book, they introduced a minor alteration, and they said growth along the intact alveolar septa. So tumor cells growing along the intact alveolar septa, that's what they made the change for this lipidic. That's what the lipidic growth pattern meant. And I'm showing a picture of butterfly on the right because there were some metaphors described as butterfly sitting on the fence. There's so many metaphors described, but there's no connection between the metaphors and lipidic growth pattern. So this is how the word lipidic came into existence by John George Adami, and then later on by Spencer's pathology book. Here, the same lipidic growth pattern, but there is little more than that. So it's not just this surface, the cells, tumor cells lining this alveolar septa, but there's little more than that. So with these big two arrows, you can see there is expansion of the interstitium here, and also there's some smaller glands. There's smaller glands here. So that's stromal invasion. So that's stromal invasion. So if you look at it, the lipidic growth pattern where there is no disturbing of the alveolar architecture, so that you can consider as a non-invasive growth pattern. So when does invasion come into existence, or when do you say that there is invasion in the slide? When you see these kind of areas. So when you see this expansion of the interstitium, and then there is smaller glands, so that means any other growth pattern other than lipidic, so then that is considered as a invasive pattern. Here it looks like acinar growth pattern. That means round glands in the fibrous or inflammatory kind of background stroma. And The other types of invasions you can expect in lung is the classic kind of invasion you see in rest of the body, where you see tumor cells in a background of desmoplastic stroma. So the desmoplastic stroma is nothing but an immature, pale, basophilic kind of tissue, fibrous tissue. So if you see that, that's also a sign of invasion, which you traditionally see in rest of the cancers. Here also you can see those kind of changes, but coming to lipidic growth pattern, this is what you should be looking for. So to contrast that, so this picture shows this round to oval gland. Some of them has got irregular too, and they are present in a background of fibrous and inflammatory cells. So this growth pattern is called acinar growth pattern. So whenever you see this acinar growth pattern, obviously that's an invasive adenocarcinoma. So here you can see the tumor cells are growing on the top of this fibrovascular core. So these are the fibrovascular core, and they are proliferating on the top of this fibrovascular core. And this is what is called as papillary growth pattern. There's some airspace fibrin too, but this is classically what is called as papillary growth pattern, which is also an invasive adenocarcinoma growth pattern. Then more important is micropapillary. So micropapillary is just little florets of cells which are freely floating and they don't have any fibrovascular cores. So this is called micropapillary growth pattern. So see the difference in morphology. So you can do a lot with histopathology because you have the power of microscope. So you can see all these beautiful different kinds of patterns under microscope. And this information is a lot of information and it's important information for treating the patients. So why is this important? Histological typing. Like I mentioned, if you have only lipidic growth pattern, what do? If you have more than lipidic growth pattern, then obviously it qualifies as an invasive adenocarcinoma. So in a tumor, you can have different patterns. You can have acinar pattern, you can have papillary pattern, or you may have more than two patterns. Then how do you say which one is predominant? So again, that's where there's some common ground rules by the WHO classification. They said that you should report these percentages in increments of 5%. That means anytime you have a 5% growth pattern, you have to report that. Say, for example, but the most important is the predominant growth pattern. Predominant growth pattern is the greatest percentage, not like more than 50%. So it's if you see a 30% acinar growth pattern and the rest of the patterns are less than 30% in that tumor, then you would call that acinar predominant adenocarcinoma. So that would fit into that WHO classification of acinar predominant adenocarcinoma. But there's one important rule here. For micropapillary pattern, even if there's more than 1% presence of micropapillary growth pattern in the tumor, it's important that you mention that because that can adversely affect the prognosis. So for all of the patterns, except micropapillary, you mention the predominant growth pattern, but if there is a micropapillary pattern, you still mention the predominant pattern, which could be other than micropapillary. Traditionally, there's more papillary pattern, that's what you expect, but any amount of micropapillary pattern, you mention it, so that's what the information you're going to give to the surgeon. Again, this is from the International Association of Study of Lung Cancer, American Thoracic Society, European Respiratory Society, classification of lung adenocarcinoma. And what I'm trying to show from this article from Yoshizawa, which was published in 2011, is disease-free survival. So x-axis, you can see years after surgery, and y-axis, you can see probability of recurrence of these different patterns. And you can see here, adenocarcinoma of in situ, minimally invasive adenocarcinoma. Their various patterns are listed here: lipidic, papillary, acinar, mucinous, colloid, solid, and micropapillary. So if you look at it, so adenocarcinoma in situ and minimally invasive adenocarcinoma, They put them into favorable group because they had 100% disease-free survival in 5 years, at 5 years. There were intermediate groups in between this unfavorable and favorable. Those included your lipidic, papillary, acinar, predominant adenocarcinomas. So whenever you see the lipidic adenocarcinoma, so that would still be an intermediate group. Again, we'll go on to discuss the difference between adenocarcinoma in situ, minimally invasive adenocarcinoma, and lipidic predominant adenocarcinoma in the next few slides. So the unfavorable group, as I told, I've been impressing upon you is micropapillary. Other than that, there's also solid growth pattern. And there is also colloid, mucinous, and mixed adenocarcinoma. Mixed adenocarcinoma means your mucinous component and non-mucinous component. That's what I mean by mixed adenocarcinoma. Again, one pattern I did not mention is that's cribriform. So like I mentioned, the cribriform pattern was not included when this study was done. But later on, there were several studies later where they looked at the cribriform growth pattern or the complex fused glands like growth pattern, like what you expect in prostate cancer. When you're doing Gleason's grading, you have this fused kind of gland. So similarly, the acinar growth pattern can have some fused kind of glands. So there were several studies published later on looking at this complex growth pattern, especially cribriform, and they said that this is also one of the adverse, having bad prognosis as far as the patterns, histologic patterns are concerned. Again, the point of the day or point of this slide here is the micropapillary predominant adenocarcinomas are the least favorable. That's the point. Again, cribriform pattern. So you can see here, there were several studies. I just mentioned one studies here. There was also a study by Dr. Andre Moreira from New York, and there are two more studies. I just put one study here because that was the latest one. Um, again, you can see this complex growth pattern of this tumor cells forming this cookie cutter spaces. And also the other name is Swiss cheese appearance. So, and also you can see this pattern in various other tumors like adenoid cystic carcinoma and salivary gland. So also you can see in breast cancers, there's a invasive cribriform carcinoma in breast cancers. And also the cribriform growth pattern like ductal carcinoma in situ. So that's also another example where you can see these growth patterns. There's also abundant necrosis going on here in this slide as well. But the importance of this pattern is it is associated with a higher TNM stage and they're also associated with lymphovascular invasion. And some of the studies have showed that this ALK rearrangement that would be important. And some studies also showed that they can be HER2 mutation. And they have a worse overall survival than acinar growth pattern. And they're yet to be included in the WHO. Probably the next WHO they might include it. Again, in the recent last USCAP 2019, Dr. William Travis from Memorial Sloan presented this talk on newly recognized filigree growth pattern. So you must have seen this filigree growth pattern. These are nothing but finger-like projections where the tumor cells grow vertically and horizontally. So they'll have a narrow stacks of tumor cells lying one above the other, like piled up, and at least 3 piled up nuclei from the alveolar wall basal layer, and up to 3 cells in width. So 3 up, 3 lateral, and they don't have any fibrovascular core. So this picture is from the article, from the journal article Emoto K et al. They published in Journal of Thoracic Oncology. So unlike the true papillary pattern, they're trying to compare it with a true papillary pattern. So you have fibrovascular core. But in the micropapillary, this filigree micropapillary, so far what we knew was a classic pattern or the classical micropapillary pattern. So where the tumor cells grow in the florets, in the form of florets, like I showed you in the previous picture. But this pattern, you will see it will have this piling up of cells, one like stacks of cells, one above the other. So again, in their article, they studies a significant number of stage 1 lung adenocarcinoma. Imagine this is just stage 1 lung adenocarcinomas. That's why I was telling you any micropapillary pattern you got to mention in your report, because that's important, because that carries adverse prognosis. So they looked at significant number of stage 1 lung adenocarcinomas, and they saw that this filigree growth pattern was frequently seen along with classical floret kind of micropapillary pattern. So again, they also said that it carries a similar kind of prognosis. That means already micropapillary doesn't have a good prognosis, it's bad. So it's similar to the classical micropapillary pattern. But if you see it, mention it in the report in the comment, so that the patients will get what patients would be treated for this micropapillary growth pattern. So I think, so that's the end of the challenge one, where we looked at the different patterns and everything. Again, we did not completely do a closure for the lipidic growth pattern, because that's what I'm going to take it to our second challenge. That means, what do you do when you see a lipidic growth pattern on the needle core biopsy? So normally, when we get a fine needle core biopsy from our interventional radiologist, we get smears, and also we get aspiration, and also we get needle core biopsies. So we have touch preps of our cytology colleagues would look at them. They also get this needle cores. They look at them along with the smears. So what do you do when you see lipidic growth pattern on the needle cores? So there could be several possibilities. There could be adenocarcinoma in situ. There could be minimally invasive adenocarcinoma and invasive adenocarcinoma. So can you really make a distinction between these three entities in a needle core biopsy if you see lipidic growth pattern? That's what we're going to answer. That's what is a challenge we face when we see this lipidic growth pattern. Again, what's the difference between adenocarcinoma in situ? And I did not mention this, but there was one more pre-invasive lesion which I mentioned you in the WHO classification slide, that is atypical adenomatous hyperplasia. So what's the difference? So absolutely, when you look at this bottom left of the picture, this is the whole slide scanned image. You can see a smaller area of increased cellularity of the cells, increased cellularity compared to the background alveolated lung parenchyma. So the same picture is magnified here. So when you see on higher magnification, you can see this single layer of cells. Most of the places is single layer. I don't see much stratification in this area, and most of the cells has got gaps between them. So most of the places they've got gaps between them. Otherwise, it doesn't disturb the alveolar architecture. It is just lining the pre-existing alveolar spaces. So how do we differentiate? How do we differentiate atypical adenomatous hyperplasia from adenocarcinoma in situ? Again, mind you, these are non-mucinous adenocarcinoma in situ because we don't have any mucinous cells here. So I'm going to discuss the mucinous in next few slides. So right now we are talking about how we differentiate atypical adenomatous hyperplasia from adenocarcinoma in situ non-mucinous type. Again, the measurement is important. So atypical adenomatous hyperplasia is small, less than 5 millimeters or 0.5 cm. Adenocarcinoma in situ is 0.5 cm to less than or equal to 3 centimeters. Both are localized. Both have pure lipidic growth pattern. This one has gaps between the cells, whereas adenocarcinoma in situ, they're more crowded, more cellular, they're more cuboidal, more columnar. Columnar is more mucinous one, not the non-mucinous one, and both are TTF1 positive. So how do we differentiate? Again, other than looking at the gaps between the cells and cellularity or crowding and everything, on imaging, you can see the difference as well. So atypical adenomatous hyperplasia cannot be seen on imaging, while adenocarcinoma in situ, you can see some ground glass opacities on imaging. So ground glass opacity is just like an haziness on the chest CT, where you can still see the background vasculature. So that's ground glass. If it becomes solid, then you don't see the background vasculature. And it's important to understand that both atypical adenomatous hyperplasia and adenocarcinoma in situ, there's a morphological continuum between these two entities. So in the same lung resection specimen, you can have all of this. And you can also have invasive adenocarcinoma also. So again, if you have all of this, and if you're dealing with a primary lung cancer versus metastatic lung cancer scenario, you favor primary situation here because you already have a pre-invasive lesion, and then you have this morphological continuum leading to invasive adenocarcinoma. So you favor a primary process. So you don't even do a stains there. You didn't spend a single dollar on doing an immunohistochemistry stain. You did not uh, do any of those fancy stains to differentiate, but still you can tell with enough information on H&E the difference between primary and metastatic. It may not be possible in all the cases, but if you see it, at least in few cases, if you see this morphological continuum, that again supports a primary process, primary lung adenocarcinoma. So both these entities, atypical adenomatous hyperplasia and adenocarcinoma in situ. So you should not see any invasion, no invasion. Again, there are different types of invasion. Stromal, like I showed you in the previous slide, lymphatic or arterial, pleural invasion, and also STAS, spread through 8 spaces, which I'm going to talk later. And no invasive growth pattern. So any growth pattern other than lipidic or invasive growth pattern. It could be acinar, it could be papillary, it could be micropapillary. If you see that, then it's invasive adenocarcinoma. So again, how do we differentiate minimally invasive adenocarcinoma? So again, the sizes, they're usually solitary, they're usually less than or equal to 3 centimeters, but the invasion should be less than or equal to 5 millimeters. That means if the tumor is predominantly lipidic growth pattern, the tumor is exhibiting predominantly lipidic growth pattern, you have a small area, like here, where you see stromal invasion, or where you see a different type of histological pattern like acinar, like papillary, then and that invasive growth pattern, if that amounts to less than or equal to 5 millimeters, then it's minimally invasive adenocarcinoma. There can be a situation where the tumor is more than 3 centimeters with invasion size less than or equal to 5 millimeter. Then you can say it's a lipidic predominant adenocarcinoma suspect, minimally invasive adenocarcinoma. So what do you do when you see lipidic pattern, only lipidic pattern in your needle core biopsy? So then you can say adenocarcinoma with lipidic pattern, growth pattern, with this comment saying that you can't make a distinction of if it's coming from adenocarcinoma in situ or minimally invasive adenocarcinoma or just lipidic predominant adenocarcinoma in this biopsy. So you're reserving the final diagnosis for a resection specimen. So why can't we tell the difference? Because we don't know from where they're getting the biopsy, right? On imaging, I was telling you, we don't know if they're getting the biopsy from a solid area or a ground glass opacity. We don't know that information. So it would be best to reserve the final diagnosis on the resection specimen. So that's our second challenge. Next, move on to the third one, challenge 3. So lipidic growth pattern in mucinous tumors. So previously the mucinous bronchiolo-alveolar carcinoma, that term is no longer used in the current WHO. So the updated term is mucinous, invasive mucinous adenocarcinoma. Again, I just put this briefly, the immunohistochemical profile, because most of the time you end up with this uh, confusion in the immunohistochemical profile, especially for invasive mucinous adenocarcinomas. Because the traditional markers many institutions still do is CK7 and CK20 and a TTF1. So most of the cases is CK7 positive, CK20 is positive in 50% of the times, whereas TTF1, you can see it's present only in 15% of the times. That means invasive mucinous adenocarcinoma has got a very low TTF1 positivity rate compared to a non-mucinous adenocarcinoma of the lung. If you do a TTF1 on acinar adenocarcinoma or a lipidic adenocarcinoma or a papillary micropapillary, they're TTF1 positive. But if you do a TTF1 on invasive mucinous adenocarcinoma, most of the times they are negative. And with CK20 being positive, you can also add one more marker, sometimes CDX2. That's a nice nuclear marker, which looks at intestinal differentiation. Even that would be positive. So you have a profile, you have a mucinous carcinoma biopsy sitting in on your microscope, and your TTF1 is negative, and your CK20 and CDX2 is positive. So that immunoprofile is very characteristic of an intestinal differentiation. So now, would you sign that as a metastatic adenocarcinoma, or would you still worry about a primary lung adenocarcinoma? Then what do you do? So that's the situation you will often find yourself as far as the mucinous adenocarcinomas of lung are concerned. So again, on morphology, you'll just see a lot of these mucinous cells, right? So you can see they're growing along the alveolar septa, and then it's got a lot of mucin. On higher power, you can see they are columnar cells with a basal nuclei. And the mucin is at the apical part of the cell. So the reason why they converted, or they call this invasive mucinous adenocarcinoma, because already I showed you that disease-free survival. In that, this mucinous adenocarcinoma, they behave badly. And most of this invasive mucinous adenocarcinoma, even though they can have this lipidic growth pattern on your biopsy, they still clinically they tend to present with multiple nodules. They tend to present with bilateral lung involvement. Multiple lobes of the lungs are involved. And they can also present as lobar consolidation. And more important is they have a KRAS mutation. Most of them are KRAS mutations. And again, KRAS mutations is something where you don't have a targeted therapy. Unlike EGFR, unlike ALK mutations, ALK rearrangements, not mutation, ALK rearrangement, or ROS, where you have a specific targeted therapy. For KRAS mutations, you don't have a specific targeted therapy, but there is recent clinical trials going on, which I did not get the reference for that, but I can send you if you're interested. There's recent trials going on KRAS where they are looking at the ones with KRAS G12C mutation. So those are showing some promising results. So be keep it tuned on this KRAS mutation, so that there'll be some targeted therapy in the future. And then clinically, they have aggressive clinical course. And in small biopsies, we tend to diagnose this or report it as adenocarcinoma with mucinous features. So that's challenge 3. And next we'll move on to challenge 4. So what do you do when there's a non-specific immunohistochemical profile? So traditionally for the lung biopsies, we do TTF1 and P40. That's the go-to markers I do when I have a question of lung adenocarcinoma. So TTF1 stains all the adenocarcinomas, while P40 stains all the squamous cell carcinomas. Again, a small example here. So these are cell blocks, specimens, and you can see this pleomorphic cells, H&E image, and there's no formation of glands or any keratinization in this lesion. But when we did the immunohistochemical stains for P40, they were positive, but not in all the cells. Some cells were positive. TTF1, some cells were positive. So what do you do when you have this kind of immunostain profile, when both the stains are positive, TTF1 and P40? So we need to get some basic rules, ground rules. So this is a nice article, yet happy. So it was published in Journal of Thoracic Oncology. So they set some ground rules. Um, so what's the cutoff for staining for P40? So when is the staining significant? So 50% is a cutoff in the tumor cell nuclei. So if you have a slide which has got both TTF1 and P40 positive, and again, if the P40 is very patchy, but TTF1 is also patchy, then you give significance to TTF1 because TTF1 focal positivity trumps focal P40 positivity. And again, you should look at the proper clinical context because that's important. I'll tell you what's the proper clinical context for the TTF1 staining. There's a classic example I'll be telling you in next few slides. So 50% cutoff is important for P40 for tumor cell nuclei. Again, little bit about P40. So most labs still do P63 for identifying the squamous cell carcinomas. Many labs still do CK56 also. Uh, if you're doing CK7 for adenocarcinoma, they can still be positive in squamous cell carcinomas. Don't be surprised with that because CK7 is non-specific. That's why per WHO, they don't recommend CK7 positivity to classify the tumors as adenocarcinoma. They always recommend TTF1 positivity to classify adenocarcinoma. So if both TTF1 and P40 is negative per WHO in a biopsy, then you call it as non-small cell carcinoma NOS, not otherwise specified. So P40, it's definitely sensitive, similar sensitivity to P63. Since it targets the splice variant of P63, it's more specific than P63. That means P40 is more specific than P63. That's what we want. Because P63 can be positive in so many things. It's positive in some small cell carcinomas. Excuse me. It's also positive in minority of ALK positive adenocarcinomas too. And definitely P40 has got a better sensitivity and specificity than cytokeratin 5/6, not cyclin D1. So coming to TTF1, so most adenocarcinomas are positive for TTF1. So the rate is 75 to 85. So the remaining ones which are negative for TTF1, bulk of them is this invasive mucinous adenocarcinomas. They are negative. Mostly they are negative. And there's several different clones of TTF1. The popular ones are these three big ones. So SPT24, SP141, and this long kind of name HG7G3/1. So there are three different clones of TTF1. I try to make a table so that it will be easier, but the end of the end point here is the 8G7G3/1 is more specific. It has got the highest specificity compared to all other clones, whereas SPT24 and SP141 has got similar sensitivity. They've got similar sensitivity but lower specificity. So this SPT24 is a mouse monoclonal similar to 8G7G3/1, whereas SP141 is a recent antibody and it's a rabbit monoclonal antibody. So the SPT24 is positive in few squamous cell carcinomas also, again because it's more sensitive. While the 8G7G3/1 is positive in fewer than what is positive in SPT24. The other caveat you should remember is that SPT24 is also positive in various other cancers, especially gynine cancers. It can be positive in endometrial carcinomas, ovarian carcinomas, cervical carcinomas, all three cancers. It's also positive in breast cancers, colon cancers, and gastric. Means the percentage of positivity is in few cases, not like in each and every case. But you have to remember this when you're dealing with a patchily positive TTF1. Because if you have a biopsy in your hand and that is TTF1 positive, but clinical history says patient has a different type of cancer, then you got to be careful. Then you got to be careful. So then there are other pre-analytic considerations for TTF1. Sometimes you expect the tumor to be TTF1 positive, but because of various considerations, they can be reduced staining or absent staining. Especially one of the scenarios we got is decalcifying agents. The stronger the decalcifying agents, it can make this TTF1 positivity rate to reduce. That's why we use EDTA, which is kind of a softer kind of decalcifying agent, and it doesn't disturb much of the TTF1 reactivity. Excuse me. And then alcohol-based fixatives, especially cytolite for cytologic specimens, can also show some reduced or absent TTF1. So this image, you can see a scanned image here where you can see the entire tumor. It's like a circumscribed mass lesion. And then you got this poorly differentiated solid kind of architecture. And most of the cells look similar with prominent nucleoli, but some areas there's some necrotizing or necrosis, like focal necrosis. So with this, when you do TTF1 and P40, and if you have TTF1 positivity like this, what do? Would you call this TTF1 positivity, or what do you want to do? So important is to notice where the TTF1 is positive. If it's positive in the tumor cells, or it's positive in the entrapped pneumocytes. So in this case, you can see it's positive in the entrapped pneumocytes. While this case at P40 diffusely positive, supporting the squamous cell carcinoma. Excuse me. So this case was signed out as squamous cell carcinoma because the P40 was diffusely positive. Like the rule is 50% cutoff, right? And also here there was no confusion here because your TTF1 was not staining the right cells. It was positive in the non-neoplastic entrapped pneumocytes. So that brings up a good point. So if you have a resection specimen and you have both TTF1 and P40 positivity, and you have a question of adenosquamous carcinoma, is that sufficient to call adenosquamous carcinoma? So let's look at this old scanned image. So you got this big tumor here, some solid areas, some glandular areas, and you got background lung. So this solid areas, I'm going to magnify that. It has a solid appearance with clear cytoplasm. Then you have this glandular areas. It's mostly acinar growth pattern. So the immunostains TTF1 is highlighting the glandular areas, while P40 is highlighting those solid areas. While the P40 is negative in the glandular areas, similarly TTF1 is negative in the solid areas. So if we go back to this original slide, so this tumor has got two distinctive morphologies. One has got glandular differentiation, the other one has got solid kind of architecture, and both of them are highlighting different immunohistochemical stain positivity. That means it is appropriately staining the appropriate cells. That means The glandular cells are stained by TTF1 but negative for P40, and the solid areas are stained by P40 but negative for TTF1. So when you have these two distinctive populations of cells, both morphologically and they stain appropriately on immunohistochemical stains, then you call that adenosquamous carcinoma. Because many times when you have patchy staining of TTF1 and P40 in the same tumor cells, that does not qualify that tumor as adenosquamous. But even in core biopsies, when you have two different types of morphology and they're staining differently for different antibodies, TTF1 and P40, you can raise a possibility of adenosquamous in the biopsy. But if they're staining in the same tumor cells, both TTF1 and P40, that's not the right scenario for raising the concern for adenosquamous carcinoma. So before the diagnosis of adenosquamous carcinoma of lung origin, also check for any history of GYN malignancies, especially in women. Because if you look at these endometrial carcinomas, they can have squamous morules, they have glandular differentiation. So sometimes they can metastatize to the lung. And there's a nice paper from Sanjay Mukhopadhyay where they talk about this late metastasis to the lung, more than 5 years duration from the primary and the metastatic process to the lung. So that's a good article to read about and understand about these cases. But how is this? Why is this important? Imagine I told you, means in the previous slides I told you that TTF1 positivity can be seen in these endometrial cancers, especially with the SP124 clone. So if in your lab you're using SP124 clone and the tumor is positive, and then patient has a history of GYN malignancy, and now would you call that adenosquamous because it has got some glandular differentiation, it has got squamous morules or squamous differentiation, or that's when the clinical history is important. That's when you have to dig into the clinical history of the patient. Many times as pathologists, we don't get much history, but it's very important that you call your clinical colleagues and check with them if the patient has got any past history of any malignancies. Any history of malignancy in the past is important because that can definitely change your final diagnosis. It could be a delayed metastasis or it could be a new primary even when the patient had a past metastatic carcinoma somewhere else. So clinical history is very important, and having a dialogue and discussion with your clinical colleagues is very important in metastatic cancer setup. So how do we deal with it? So your TTF1 clone is positive, but the patient has a GYN malignancy in the past. The best antibody situation in this situation would be Pax8. So the Pax8 is usually positive in GYN malignancies. Again, if you look at Pax8 as a immunohistochemical stain, they're positive in various cancers. They're positive in renal cancers, they're positive in thyroid cancers, but they're also positive in GYN malignancies. But if in this appropriate scenario where there is a GYN malignancy question, so the Pax8 would definitely bail you out, because there's also another article by the same group, which I did not share in this slide. They looked at a significant number of lung cancers, lung adenocarcinomas, and they said that the Pax8 is not positive in lung cancers or lung adenocarcinomas. So Pax8 positivity suggests GYN malignancy when you have this kind of clinical scenario. So that's about immunohistochemical challenges. Very few, means I can't discuss all of them. At least I got few of them. But there was a recent case on Twitter posted by Sanjay Mukhopadhyay. He's a pulmonary pathologist from Cleveland Clinic. So he also talked about this same scenario uh, where GYN malignancy history role, importance of knowing the history of GYN malignancy. The other important point I need to bring up is when you have a carcinoma in the lung where you are between primary and metastasis and patient has a history of a cancer elsewhere in the body, again, the most important would be to get the slides from the previous cancer. Sometimes a patient might have gotten treatment at a different hospital. So request for the slides and compare those slides with the slides what you got. So morphological comparison is very, very important. No matter what we do as molecularly or cutting edge technology, still the basics should be to compare the current slides of the patient with the patient's previous slides to see how morphologically they look like. If they look similar, you got your answer. If they look different, then still you got your answer in the direction where you want to go. So having said that, let's move on to our next challenge. Challenge 5. How do we differentiate stacks from stacks? So stacks is spread through edge spaces, stacks is spread through knife surface. How do we differentiate these two? Why is this important? So the places where you follow the CAP cancer protocol, they've already included this in the CAP synoptic template for lung cancer. It's still optional. So spread through edge spaces not identified or present. And again, there are several definitions for spread through edge spaces based on the different articles. These are some of the biggest studies of STAS. You can see the number of cases here and the stage of lung cancers they looked at. The first person they looked at was Onizato. He was seeing tumor cells at the periphery of the tumor, means there were islands of tumor cells at the periphery of the tumor mass. Means if you saw the well circumscribed lesion, you were seeing some islands at the periphery, separated by few alveoli. So they described this as tumor islands. Later on, so this was the first paper, Cadota 2015 from the Memorial Sloan with Dr. Travis. So they looked at stage 1 lung adenocarcinomas, 411. So they saw micropapillary clusters, solid nests or single cells in the air spaces beyond the edge of the main tumor. So it's like the border area. So around the border area, outside the main tumor, edge of the main tumor, you see this micropapillary clusters, solid nests or single cells. Again, there were subsequent studies in the same year, Warth from Netherlands. So he also saw similar kind of small cell nests. He classified less than 3 alveolar away from the tumor mass. He said he gave a number, at least 5 tumor cells, limited stas if you see less than 3 alveolar spaces from the main tumor mass. If they're seen more than 3 alveoli away from the main tumor mass, then that's extensive stas. Then Morimoto saw the same thing. And similarly, other studies. So WHO classification for stas. So there's so many different findings in this different studies, but the point is these are micropapillary tumor cells or micropapillary cell groups, solid cell nests or single cells found within the air spaces beyond the boundary of main tumor mass. So that's the WHO definition for STAS, spread through air spaces. And they also said that this is another criteria defining the invasion. So if you see this along with a lipidic kind of adenocarcinoma, obviously it becomes an invasive adenocarcinoma because they consider this as a type of invasion apart from the other types of invasion. Again, this is a scanning microphotograph. So you can see there the tumor on the right side and this area is separating the tumor. So that's a main mass. You can see where this area is taken here, the red box. And you can see the tumor cell clusters. They're forming some ring-like structures here, and they're in the alveolar spaces floating. So that's exactly what I was telling. It's called as TAS. So the previous slide was adenocarcinoma. This one is a neuroendocrine tumor. So the first descriptions about adenocarcinoma, and later on there were several studies to show that the STAS phenomenon can also be seen in other tumors, important in squamous cell carcinomas. You can also see STAS in neuroendocrine tumors. So here it's a carcinoid tumor. So it's a neuroendocrine tumor, carcinoid tumor. You can see the outside of this border of the lesion. You can see the same tumor cells in the air spaces. And if you see, it's a continuum. It's a continuum. There is no gap or gap in between this or discontinuity in these tumor cells floating in the air spaces from the main mass to this more distant floating tumor cells. So that continuum is important for you to think that it is STAS and not an artifact because of the knife surface. This is higher magnification. One of the most important challenges we have is to differentiate these floating tumor cells from this benign looking cells, which are also in clusters. And we have more of them in the alveolar spaces. So these are your alveolar macrophages. So it's important to differentiate our floating tumor cells from these alveolar macrophages. And also there's one more image here. You can see this the locations on the periphery of this big mass. There are more macrophages. You will not have difficulty differentiating this because it has got more foamy character. But the previous one, the previous image I showed you, so there you have to be careful when they're forming that cohesive clusters. Then you have to be careful. And also you can also see there's a fibromyxed flux of organizing pneumonia here mixed in with this plasma cells. So sometimes this can only be this can be sampled in your needle core biopsy and you see only this and not tumor. That's when you have to put in a comment saying that you're seeing some organizing pneumonia, but clinically they're suspecting mass or a lung cancer, but you're not seeing the lung cancer cells. So you put in a comment saying that the needle must have sampled the organizing pneumonia, which is present in the adjacent areas of the tumor mass, and ask them to do a close clinical follow-up and maybe repeat the sampling. So that's the best you can do when you see only organizing pneumonia in your small needle cores. Coming back to the point, STAS. So make sure that you don't misinterpret these floating tumor cells and keep it away from interpreting them as macrophages. Again, I told you that's the first kind of study, 2015 Cadota et al. They looked at 411 cases. Out of them, 155 cases had STAS. And in most of the cases, the STAS existed in first alveolar layer. And they saw three patterns. Most of the cases had micropapillary structures. Again, you have to understand these micropapillary structures was outside the main tumor mass. If you see these micropapillary structures within the tumor mass, then that's a micropapillary growth pattern of the adenocarcinoma. So you have to see where's the location. That's also important. And then they also saw solidness or tumor islands and single cells also. And most of the cases in their study, the edge of the main tumor was smooth, and the distance between the tumor surface and the farthest STAS was 1.5 millimeters. And lipidic pattern was less frequently observed. That means this, the lipidic growth pattern, you don't find STAS much with the lipidic growth pattern. So the importance of this study was they said that it's a risk factor for local recurrence. So if you look at this treatment of lung cancers for stage 1 lung cancers or small tumors less than 2 millimeters, the recommendation is lobectomies. But over the past few years, people have gotten to wedge resections where they try to save the lung because most of these patients have a smoking history. So they're trying to save the lung as much as possible. So they go for limited wedge resections. And most of the decisions of limited wedge resections are taken based on the tumor size. So this study especially was important in such a way that other than tumor size, there are other risk factors we need to consider before putting the patient for a limited wedge resection or before considering a limited wedge resection versus lobectomy or a big procedure. So to decide the surgical management or a type of surgical procedure, this is important. So they said that risk factor for recurrence is high in limited wedge resections if those tumors had STAS. And they also said that it was an independent and the only risk factors of any recurrence in multivariate analysis, while they did not see any increased risk of recurrence in lobectomies. So what is spread through knife surface? How does those look like? I mean, so far means this there was this discussion in the pulmonary pathology world that when we saw this TAS or floating tumor cells, we said that, oh, it could be because of knife surface, spread to the knife surface. Again, the tumor cells can spread into the air spaces by knife during pathological examination while you're grossing cutting the specimen. And higher grade tumors such as micropapillary adenocarcinomas are more prone to dissociate during sectioning. So that's also a reason you can explain why the STAS is associated with higher grade tumors and not the lower grade lipidic kind of tumors. So it's very important to differentiate between these two, artifacts and STAS. And also macrophages, I already mentioned to you. Some of the macrophages can have Smoker's pigment, the fine yellow granular pigment. And along with the yellow pigment, you'll also have some dark pigment, which I showed in the previous slide. So alveolar macrophages, try to differentiate from them. But more importantly, how do you differentiate from artifacts? So if in question, you can do a keratin stain, and that would be positive. But that only helps you from differentiating from alveolar macrophages, not from these artifacts. So you got to be really careful. If you see randomly scattered clusters of cells or a tissue under the edge, it's most probably artifact. And again, remember I was telling you the continuum of cells of these floating tumor cells from the edge of the tumor to the distant area. So there should be a continuum of cells. If there's no continuum of cells within the edge spaces and some random tumor cells are present distantly from the main tumor mass, then that's probably more artifactual, not STAS, not the real STAS. And also, because of the jagged edges, you can see some linear strips of cells lifted off from the alveolar wall. Then you'll have an elongated, means a long linear kind of stripping of cells. Then you should think of artifact in that scenario too. So having said the difference between artifact and STAS, let's move on to what's going on in the world of STAS. So recent USC CAP meeting at Los Angeles, there were at least, I think, couple of platform presentations on intraoperative evaluation of STAS. That means they looked at the STAS during frozen section. Means traditionally we do frozen sections for tumor diagnosis and margins, more importantly. But some studies, especially from Boston, they looked at intraoperative identification of STAS during frozen section. It's important again to differentiate the STAS on frozen sections from artifact because you're cutting the unfixed lung tissue. So it's important to rule out artifacts. And more important was sampling, because like I mentioned, the STAS is seen in the adjacent alveolated lung parenchyma. So if you just sample the tumor, obviously you'll have no opportunity to look at the STAS because you have to have some non-neoplastic lung parenchyma to assess for the presence of STAS. And again, the intraoperative consultation, obviously you can tell the surgeon if you're seeing the STAS, then you can encourage the surgeon for converting into a lobectomy if he is planning to do a smaller wedge resection. Again, there is no sufficient data. None of the studies so far have predicted the value of intraoperative STAS assessment. So we don't have clear-cut recommendations at this point of time because the studies so far have not been very conclusive. But I'll show you some studies, especially this study by Dr. Waltz, published in Archives in 2018. So they looked at 48 cases of resected lung adenocarcinomas, and they tried to compare the presence of STAS both in frozen section and the permanent sections. Obviously, permanent sections, they had luxury of adding more sections. In frozen section, we are limited by the number of sections because the time is the money there. So we're trying to get the diagnosis as early as possible. So in their study, they found STAS in 95.8%, and 50% of those cases had STAS on frozen section. So the sensitivity was 50%, while positive predictive value was 100%, negative predictive value was 8%. So they concluded that insufficient data to support this as a predictive feature to stratify the patients for lobectomy or sublobar resections. Again, like I was mentioning you, sampling the adjacent lung parenchyma is critical for you to evaluate STAS. So if you consider this the tumor with that green circle, there's also some big holes here. That's all artifactual. So those could be because of the artifacts. So it's important if you see tumor cells floating in these big spaces where the blue arrows are present, those are artifact, those are not STAS. But if you see it around these spaces and in a continuum fashion, then you say that it's a real STAS. Then you give that information to the surgeon. At this point of time, we don't have clear-cut recommendation. Again, this is our frozen section. Courtesy, this pic was contributed by my fellow Dr. John Edwards. So you can see the frozen section. There was STAS present, that's a high magnification. It's present adjacent to the main tumor mass, whereas on the permanent section also it was present. So that's a perfect concordance. So definitely we can evaluate STAS in frozen section, definitely, but make sure you have enough non-neoplastic alveolated parenchyma adjacent to the tumor mass. There was other studies, Iguchi et al., 2018. So they looked at the STAS on frozen section, and their sensitivity and specificity was better actually. It's definitely more than, definitely better than the previous study what I showed you. So the sensitivity was 71%, and the specificity was 92%, which was which was a bigger jump from the 50% sensitivity from the previous study. And there was one more study, or this is from the Histopathology journal recently. Dr. Shi, AR, and Mary Minu Kennardson, they wrote this review article, and they do mention that frozen section is highly specific but not sensitive for the diagnosis of STAS in early stage lung cancer. And they had a fair, only fair interobserval agreement at frozen section. Again, there was other studies too, like especially Morimoto, other studies too, and they also said that it's not a good idea to evaluate STAS on frozen section because the alveolar spaces are not inflated. So there's still lots of discussion in this space. So tune in for more details on this in the future. So the point is exclude artifacts before ascertaining that it's STAS. So they could be random clusters of tumor cells at edges, so that's artifact. And then clusters not in continuum of air spaces present distally, artifact. Linear strips of cells lifted off alveolar spaces, artifact. Then transplantation of tumor cells in air spaces through jagged edges, artifact. So make sure you differentiate artifact from real STAS. I think that's we are done with that. And next, briefly, I'm going to mention molecular profiling of lung adenocarcinomas. As you know, recently we have been adding a lot of targetable mutations in lung adenocarcinoma because of extensive research going on in this area. So 75% of the genetic alterations promote this pathway, RTK, RAS, RAF signaling pathway. And the most common mutations in lung adenocarcinomas involve KRAS, EGFR, and BRAF. Like I mentioned to you, EGFR and BRAF has got a targeted therapy, but KRAS, we have some promising results in some clinical trials recently. So watch out for the space. That would be interesting. There are some less common genetic alterations like MET exon 14 skipping, then HER2 mutation, ROS1 fusion, ALK fusion, especially the fusion genes, then NRAS mutation, HRAS, and then MET amplification. So EGFR mutated adenocarcinomas, they're more commonly characterized by East Asian ethnicity, female gender, and they will have light smoking history or no smoking history. TTF1 would be positive. Sometimes the tumor cells can have some obnale cell kind of appearance. And even with adenocarcinoma with micropapillary pattern, they can have a higher frequency of EGFR mutations. Then fusion genes also can be rearranged, especially when they're involving ALK, ROS1, RET, NTRK1, and NRG1. Again, these also have good response to targeted drugs. So there's several FDA-approved drugs for these targetable mutations. Again, this pic is contributed by Dr. Sanjay Mukhopadhyay, permission obtained from him. So this is an ALK rearranged adenocarcinoma where you can see the tumor cells has got a mucin kind of morphology to it with an acina structure. And generally they're TTF1 positive, and they are positive by this immunohistochemical stain. And also there are different clones for ALK, and this particular clone called D5F3, so it should be D5F3. So D5F3 clone. So that clone, when you see positivity with that clone, that is equivalent to ALK fish. So instead of doing just ALK fish, you can do this IHC stain if you have this ALK clone in your lab. The importance of this is your genomic testing. So we do next generation sequencing in our lab. It takes about 2 weeks time for the genomic testing to come back. So we also have this D5F3 clone. So if the tumor is positive for ALK rearrangement, then it will show the staining as cytoplasmic staining. And immediately you can tell your oncologist that there is an ALK rearrangement in this patient, and if the patient, if there's an indication for the drug, they can start the drug specific therapy, ALK inhibitors immediately. So that's the beauty of this immunohistochemical analysis for ALK by this D5F3 clone. And also it's the same thing, the ALK rearranged adenocarcinomas, they're also seen in younger onset people, and also with light smoking or no smoking history. Similar to ALK, ROS1 and RET rearranged adenocarcinomas, they are also small percentages, and they've got similar histological appearances similar to ALK rearranged adenocarcinoma. NTRK gene fusions seen in very small percentage of lung cancers across genders, smoking histories. They can have some mucinous. There's very few cases reported in the literature, published in the literature. Those have mucinous or poorly differentiated morphology, and one case had TPR NTRK fusion with neuroendocrine differentiation. Again, median survival shown in the study was 40.8 months in 10 patients with metastatic disease. Again, the natural history, we're still learning about this because of fewer cases. NRG1 rearranged adenocarcinomas. NRG1 rearrangements are generally seen in invasive mucinous adenocarcinomas, 8% to 27%. So that activates this PIK3 AKT pathway activation. So there's treatment available for this, and there was some preliminary success with treatment for this NRG rearranged adenocarcinomas. Again, more and more, when you look at more studies on this, we'll know it better. But at least for now, there is specific treatment for NRG1 rearranged adenocarcinomas. Then briefly, I'm going to touch upon PDL1 and then open the floor for questions. Um, so this table, I got it from this journal. So this is from the International Association of Society of Lung Cancer Pathology Committee. And they looked at PDL1 status from several different countries. Um, sorry for the poor, not so good clarity on this table. So the different countries you can see there: United States, European Union, Canada, Japan, Australia. So several countries, more than this, there are more countries using this. I'm sure you guys are also using this in India. Um, so most of these places is a companion diagnostic test. That means you need to have this percentage positivity for the treatment to get started. And what I want to draw your attention is the different clones here. So 22C3, SP263. So the different clones of PDL1 available, which we use to report this PDL1 expression. Again, the indications are metastatic non-small cell carcinoma. Again, it can be used as first line and second or later line treatment of metastatic non-small cell carcinomas. It can also be, in the United States and Japan, it can also be used as a first line treatment for unresectable, locally advanced non-small cell lung cancer, ineligible for operation or definitive chemoradiation. So if they're not eligible for surgery or chemotherapy radiation, then it can be used as single agent immunotherapy. It can be used as a third or later line treatment for metastatic small cell as a single agent immunotherapy also. And also it can be used as a first line treatment of metastatic non-small cell lung cancer and small cell lung cancer in combination with chemotherapy as well. So there are several indications for it. Again, this table, I got it from the IAS-LC Atlas of PD-L1 immunohistochemistry. So what I want to draw your attention is, you got the antibody clone and you got the platform. So these antibody clones are tagged to these specific platforms, and these are the drugs for those specific antibody clone. For example, 22C3, that's what we use. So pembrolizumab is a drug which is given specifically for this. So again, there's so many moving parts in the PDL1 world. That means you've got different antibody clones, different interpretation criterias, different platforms, and different drugs from different pharmaceutical companies. So there's a lot of moving parts in this PDL1 world. We use the FDA approved platform in our lab, PDL1 IHC 22C3 FormDX assay. It's an in vitro diagnostic immunohistochemistry assay, and it detects PD-L1 protein expression in non-small cell lung cancer, and it's performed on this specific platform, and it has got an automated staining protocol, and this 22C3 clone is a mouse monoclonal antibody. So this platform is FDA approved, so we use that. Again, paraffin blocks are preferred over cytology specimens which are not formalin processed. When they use other than formalin, then it's paraffin blocks are preferred. But if the cytology cell blocks are also processed the same way as paraffin blocks, then we can still use them. But the most important point is, for pathologists, for us to understand is minimal of 100 tumor cells are required for analysis. So you need 100 tumor cells. If you have less than 100 tumor cells, if the PDL1 expression is positive, you can report that. But if PDL1 is negative, then you have to put a comment saying that you don't have 100 tumor cells and PD-L1 is negative, so the repeat PD-L1 examination should be done in a resection specimen or in another specimen. So that comment is very important. When the PD-L1 is negative, if you don't have 100 tumor cells. If you have 100 tumor cells, or if you have PD-L1 expression in fewer than 100 tumor cells, then you can call it positive. Then you can call it positive, but still put a comment saying that you don't have 100 cells, which is a required minimum for analysis. And then the other important caveat you should remember is PD-L1 expression is seen in lots of other cells. That means you can see them in macrophages, dendritic cells, mast cells, T and B lymphocytes, endothelial cells. And then you have to evaluate only tumor cells, at least for in lung cancer. Because if you look at this formula, the tumor proportion score, where you see the percentage of PD-L1 staining cells within the tumor cells, divided by total number of viable tumor cells multiplied by 100. So you effectively, you have to exclude PD-L1 expression in all these other cells, which is still present in your tumor. So that's very important. And also membranous staining. So go back to this picture. Let me show you any partial or complete membranous. So if you compare this to a HER2 kind of expression, like for breast cancers, it's a similar kind of stain, similar kind of picture what you see. But in HER2, we need to see complete membranous staining. But here it's not like that. Any partial linear, okay? It has to be linear. Any partial linear or complete membranous staining is, you can count them. Cytoplasmic staining, you cannot count them on for this clone 22C3, but some other clones where you can count cytoplasmic staining. And then there is some other clone like SP142 where you can count the immune cells also. That's the example I was giving you. The PD-L1 world is has got a lot of moving parts, a lot of variability. So you have to look at the specific clone what you're following in your lab and get the data before signing out the PD-L1s on them. What I'm trying to show you is alveolar spaces with alveolar macrophages. They're beautifully positive. That's a good internal control you can get on your PD-L1 slide. And they're nicely membranous positive, membranous staining positive. So you cannot count this. So these are not counted for your final TPS or the tumor proportion score. So this is another image. You can see nice membranous staining in most of the tumor cells, but still you can see there's a lot of heterogeneity. There are some tumor cells which are not staining, some tumor cells are staining. So tumor heterogeneity is an important phenomenon in this PD-L1 expression by tumor cells. That's the reason I was telling you that whenever you have less than 100 tumor cells, it's important to put in comments saying that since there is absence of PD-L1 expression, still consider repeating PD-L1 immunohistochemistry in another specimen or a resection specimen so that you can take care of this tumor heterogeneity as well. Because if the PD-L1 is positive and imagine your patient is already in a metastatic cancer setup, this might be the only hope for the patient. So it's important you put that comment, and hopefully you can get a second specimen where the PD-L1 is positive and the patient gets treated by the immunotherapy and have some time disease-free survival. This one is a much better one than the previous one where the diffuse membranous positivity in the most of the tumor cells. And also you can see some of the immune cells in between the tumor cells, they're also positive. But again, this is an easy slide. It's fairly easy to exclude those. But sometimes you have tumor cells attached to this macrophages and lymphocytes in close opposition. That time it would be really difficult to differentiate. That's when you have to go to higher magnification and make sure they are not tumor cells, they're immune cells or histiocytes or macrophages or dendritic cells, and you don't count them for your final score for tumor proportion score. So that's about PD-L1. I just gave you a little brief little info about PD-L1. Next challenge is tissue is the issue. I'll just briefly comment on this. So there was this beautiful article by Dr. Eric Berniker, who is a Houston Methodist Hospital oncologist who pretty much treats these lung cancers. So he wrote an article to Archives Pathology, so where he talks about various kinds of aspects of the same thing. Tissue is the issue. So most of the times we get limited tissue, needle core biopsies, where we have very limited tissue. As a pathologist, I'll be thinking that, oh, I need to get the diagnosis right. So, but the importance is if the patient is thought to be a lung cancer patient, obviously limit your IHC, number of IHCs you do, that is immunohistochemical stains you do. If your lab offers dual stains, that's a great way to save tissue, valuable tissue, so that you can save this tissue for genomic or PD-L1 testing, because that becomes important, because if patients might still have some targetable mutations for which they can get some specific treatment. So limit the number of IHC. I classically do a TTF1 and P40, and some labs offer dual stains like TTF1 and CK56, or you can have P40 and napsin. So you're trying to see the both sides of the coin. You're excluding squamous cell carcinoma, confirming adenocarcinoma, or you're confirming adeno and excluding squamous cell carcinoma. So one stain, double hit. Uh, so try to save the tissue. And if you are able to do it, divide the course into two blocks, so that you have two blocks to work on, and get unstained sections right from the word go, so that you don't have to go back and cut the block and again, because every time you go cut the block, you phase into the block and you lose tissue. So those are some of the uh, ideas where you can limit, you can use the tissue judiciously, carefully. And he also mentions that if the PD-L1 results come back first, hold on to the PD-L1 immunotherapy, because wait for the genomic testing. If the patient has actionable mutations, so the patient should get the targeted therapy, not immunotherapy. So that's important. The sequence is important. The reason why, the EGFR mutated lung cancers, they can the studies have shown that they are poorly responsive to the pembro. That's nothing but the immunotherapy. Again, the sequence is important. If they've got concurrent immunotherapy plus tyrosine kinase inhibitor, again, the response is poor, and they're also prone for immunotherapy complications such as pneumonitis. So wait till the targeted mutation information is available before the PD-L1 treatment is instituted. So that's the point about this sequence of releasing the results as far as the pathology lab is concerned. So have a multidisciplinary discussion with your colleagues. If they want everything released all at the same time, you can have that. But make sure that they get the targetable therapy or targetable mutation information as fast as possible before the PD-L1, because PD-L1 is immunohistochemical stain, so you can do it in the same on the same day and the results are available. But definitely that becomes important in a metastatic cancer setup. If you already know the patient has got a targetable mutation, then that this information on PD-L1 would really help you. So that would be approach. So check for the targeted mutations and then look for the PD-L1. So I think those should be one of my last slides. Again, I'm on Twitter, so feel free to follow me on Twitter and at Raghu Pilappa, and I'll be more than happy to answer your questions. And I again thank Dr. Sandhya Sundaram, Dr. Pavitra for helping me, for coordinating um, my time and talk and everything, the time and everything, and also thank the Dean, Dr. Anandan, and also the webinar organizer, Dr. Narsimhan, at this point of time. So I will stop my talk there. and I'll let you talk.
So thank you so much, Dr. Raghavendra Pillappa. That was an amazing list of challenges that you really took us through. You also introduced some new terminologies, stacks and stats. So it was an amazing, and all your pictures were excellent. So we really thank you for this elaborate explanation of each of these difficult areas of lung pathology. And from Ramchandra and from my team here and from all the participants, we thank you immensely. And to appreciate, we are here presenting you this certificate of appreciation from our university. And this is signed by our dean. And hope that you loved interaction with us, and hope that we continue such sessions with our department and with the people out here. So thank you so much. And I also wish to put on record that Dr. Pavitra has been instrumental in coordinating this, in initiating this, and she took it through. So I'm very thankful to her. We've had plenty of questions on the on the chat box, and I hand over to Dr. Pavitra. She will read out the questions, and you can tell us your answers one by one.
Great,
Thank you so much.
you. Yeah, thank you.
The certificate will be mailed to you, and I'm sure there will be many more interactions from our department with you. I once again thank all the participants who've been, intently listening to you. Thank you so much.
Thank you.
Thank you, Sandhya ma'am, and thank you, sir. So are you able to see my screen, sir?
Yes, I am able to see your screen.
Okay, so let's seek the answers. So the first question was asked by Dr. Prashant Kumar R. Patel. What about the napsin A in carcinoma?
Yeah, so the napsin A, again, it could be positive. Sometimes we have a dual stain, TTF1 and napsin. Um, it works many times, but sometimes it's negative in mucinous adenocarcinomas too. So um, again, to answer your question, napsin A, some days it will work, some days not. So it's a hit or miss kind of scenario. But whenever you're dealing with mucinous adenocarcinomas, remember that you will not have enough immunohistochemical stains to prove it. What is more important is the clinical setup, the clinical scenario. And if in question, don't be afraid to say that you're not able to differentiate primary mucinous adenocarcinoma of lung from metastatic mucinous adenocarcinoma, especially from colorectal and pancreatobiliary origins, because they can have similar morphological and immunohistochemical profile. And the only way you can differentiate is proper workup, especially with PET staging. So they have to image the patient and see where the biggest mass and everything. So it's clinical radiological correlation, even though we hate to say that many times, but still a proper workup of the patient should be done before excluding a metastatic process. Hopefully that answers your question, Dr. Patel. Thank you for the question.
The next question, sir, is by Dr. Ahmad Khan. I wish to understand, is there any use of,
Mucinous adenocarcinoma in situ? Yeah.
Mucinous adenocarcinoma in situ.
Yeah, we can still use if it follows the same rules as the non-mucinous adenocarcinoma in situ. But again, make sure you don't have a multiple nodules kind of tumor, or it's not presenting as a bilateral involvement. Make sure you don't have that. So imaging would be very critical. If you have a small mass with ground glass opacities, and you're seeing some mucinous cells similar to adenocarcinoma in situ, you can still use it. So correlating with your CT imaging would be critical in this scenario. Thank you, Dr. Khan, for your question.
The next question is by our very own Professor Dr. Swaminathan Rajendran. How to differentiate tangential cut from microinvasion?
I generally do deeper levels. I try to cut deeper into the block and see if the tangential cut goes away and if the invasion is still there. But since it's a micro invasion, it's always a tough call. We face the same challenge similar to you, Dr. Rajendran. So what we do is we show it around. We show it to colleagues and we show it in our consensus conference and see how many of us believe that it's micro invasion and not tangential cut. But I try to get some deepers. Otherwise, if we, most of the times we end up with taking consensus on the first slide, because later on the micro invasion is gone, then what do you compare with? There's nothing to compare. So it's a difficult, it's a challenge for us too. Thank you, Dr. Rajendran.
The next two questions are from Dr. Balgis Khalil. Do you do nuclear and cytoplasmic IHC together in the same slide?
So classic combination I can tell you is the dual stain TTF1 and napsin, because TTF1 is a nuclear stain and napsin is a cytoplasmic stain. Yes, we do in the same slide. So we give two different colors, brown for TTF1, red for napsin. So two chromosomes we'll use. So you can see two different colors in two different locations. So that's an example which I can give you. But you got to be careful with adding stains, something like a stain which has got both nuclear and cytoplasmic expression. Those stains you cannot add into this dual scenario. For example, calretinin for mesotheliomas. So calretinin generally has got nuclear and cytoplasmic stain, while WT1, which is also a mesothelial marker, has got a nuclear stain. Here you cannot combine them because the profiles would overlap. So as far as TTF1 and napsin, if it allows for you to do that, you can do it on the same slide. The second question is, do you do EGF for ROS ALK? Yes, yes. All lung adenocarcinomas, we have an in-house gene panel. Right now we are covering 50 genes, but we are increasing it up to, I think, 150 or 140 pretty soon. But we also do ALK, ROS, RET, FISH, and also we do PDL1 for all lung adenocarcinomas. The other part of the question I can tell you is for lung squamous cell carcinomas, we don't do any of those targetable mutations, but we do PDL1. So hopefully that answers your question, Dr. Khalil. Thank you for the question.
The next question is from Dr. Kumura PN, sir. How to differentiate adenosquamous carcinoma and mucoepidermoid carcinoma?
So the differentiation might be difficult. That's a great question, Dr. Kumar Guru. Mucoepidermoid, obviously, you should have, along with the mucinous and squamoid differentiation, you also look for those intermediate kind of cells. And the best confirmation would be by looking at the cytogenetics for the MAM-L2 translocation. In cases of confusion, we send it for that translocation. But the site of the tumor also would help you. Mucoepidermoid, they're usually larger airways, while adenosquamous is more in the peripheral lung. So if you have a tumor arising from a larger airways and you have only two components and you have adenosquamous in the differential, I would submit the entire tumor. I'll go back to the gross room and submit the entire tumor and look for those intermediate cells. If I don't see them, still you can't differentiate this adenosquamous from mucoepidermoid. I would say that this differential diagnosis exists and I would send it for translocation. That's what we do in our lab, other than showing it to the experts who look at this all the time. Hopefully, I answered your question, Dr. Kumar Guru. Thank you for the question.
If the next question, personally, clone of TTF1 would you prefer in routine immunohistochemistry? This is
That's
by
a
our,
great question. That's a great question, Dr. Madala. So
this
that's
is
a great question.
she is supposed to be our alumni
Yeah,
and
I
a
would one
postgraduate.
yeah, one clone I would prefer is 8G7G3/1, the specific clone. I think I would put my money on that because when you have most of the time you have primary versus metastatic setup. In that, this works like a charm. So I would personally use that clone.
Next question is from Dr. Anirudhan. What is the therapeutic and prognostic implication of STAS? Does it
So that's
positivity?
yeah. Thank you, Dr. Anirudhan. So we're still understanding about this. Many studies they give the distance of stars from the margin, and some studies say that if the distance of stars from the margin, the closest margin, which is a parenchymal margin in case of a wedge resection, if that distance is less than the tumor dimension, then there is increased risk of recurrence. Again, that's with some studies. So obviously, if this TAS is present closer to the margin, that increases the risk of recurrence, local recurrence. So that's the implication. So if patient might come back with a local recurrence, then patient might need additional surgery, and also by the time patient would have metastatized. Um, so it does not imply margin positivity, because for margin to be positive, you still need tumor cells at the ink at the margin. So obviously, we're still this task is evolving. Um, so that's what I can tell you at this point of time. But thank you for a great question.
Next question is from Dr. Ramaswamy. Should we report micropapillary clusters in STAIS similar to adenocarcinoma? Please comment.
No, I generally am not doing that. We don't have to tell the type of stas. As long as you identify stas, if you're following the CAP synoptic template, you just say identified. Um, I have to go back and look at the studies to see if there's any real difference between different types of stas. Was there a difference between micropapillary clusters versus solid versus single cells? Right now, we have just mentioned identified, present, or absent. Um, we don't say that this specific micropapillary clusters are present, type of stas is present. But for micropapillary pattern for adenocarcinoma, you should definitely mention that. Thank you for your question.
Next question is from our very own surgical oncologist, Dr. Jagdish Chandrabose, sir. Thank you, sir, for watching us. How to differentiate metastatic squamous carcinoma, HNE from primary lung squamous, that is second primary.
Thank you for a great question, Dr. Jagdish Bose. I had actually put these slides in my talk. Actually, um, again, one of the ways to differentiate is you all know that P16 can be positive in some of the tonsillar squamous cell carcinomas or oral cavity squamous cell carcinomas. But most of the times we encounter P16 negative squamous cell carcinomas, then we are at the decision making whether it is primary or metastatic. So generally what I do is I look for any in situ lesions within the lung. If there's a squamous cell carcinoma in situ in the small airways, I try to hunt for them. So if I see those in situ lesions in the lung, and if you sometimes you're lucky enough that you see the invasive squamous cell carcinoma arising out of this in situ squamous cell carcinoma in situ lesion, then you can say that it's primary. And also the other important thing is the background changes in the lung would tell you a lot. So if the background changes has got smoking related changes, patient is a heavy smoker and you have all the features of a central squamous cell carcinoma on imaging, where it is a big tumor in the hilar region with hilar mediastinal lymphadenopathy, and so correlating with your radiology, and then smoking related changes in the background lung and in situ lesion, then I could fairly suggest that it's a lung primary, not metastatic process. And also, if you have slides from the previous head and neck primary, comparing them would also help you a little bit, but I feel these features would help me more in differentiating, and we see this every single day. That's a great question. Thank you very much.
Yeah. So by Dr. Nitesh, is there any association of STAS with desquamation in sputum sample?
So STAS we only evaluate in the resection specimens, so we don't look for them in other specimens. So it's only those complete lung resection specimens we look for STAS, not in other places. Hopefully that answers your question. Thank you.
Yes, so we are all done with the question and answer session. Thank you so much.
Oh, that was wonderful. Yeah, I'll share my email ID and with you guys, and if you guys have more questions and everything, feel free to email me the questions.
Thank you so much, sir. So
Absolutely.
yes, respected all, we are almost at the end of the session. Hopefully, I will not take much of your time to end it up with a sweet thank you note. On behalf of Department of Pathology, Sri Ramachandra Medical College and RI, feel honored and privileged to propose the vote of thanks. We wish to express our gratitude to our Chancellor, Thiru V.R. Venkatachalam Sir, and our Pro-Chancellor, Mr. R.V. Sengutavan Sir, for encouraging and providing us a stimulatory environment and architecture for such educated developments. I convey my deep regards and hearty thanks to our guest speaker, Dr. Raghavendra Sir, who had agreed in a whisk of a second to be a part of our first lockdown webinar program. And we would also like you to know near future, we will be knocking in your Twitter account to collaborate with us more for these kind of educational programs and research. We are extremely grateful to our Vice Chancellor, Professor P.V. Vijayaraghavan, for his kindness and continuous support. My heartfelt thanks to Medical College Dean Dr. Anandan Sir for his gracious virtual presence in spite of his busy schedule at this lockdown moment in administration and in clinical practice. This program, believe me or not, this would not have been possible without the constant help from Mr. Narasimhan Sir, our Vice Principal of Allied Health Sciences, organizing the schedule from his place. My pillars of support, no words to the communication team, Mr. Vasant and Mr. Joe, who had been giving me a constant support and still sitting behind me and guiding through, though it has been late evening in India. My enormous respect and heartfelt thanks to Dr. Sandhya ma'am, her head of the department, and our guardian angel too. My special thanks to Dr. Ritika and my postgraduate, Dr. Gayatri and Dr. Josephine, helping me through the webinar. My extended thanks to all the other officials, faculties, graduates, and alumni and technicians of our department. At last, but not the least, above all, I thank all the participants who had joined from various institutions, hospitals, states, and countries. If not for your participation, this webinar would not have been in the success mode. Thank you for all once again. Be the hope, be safe, and stay safe. The certificates will be reaching you within an hour's time. And we have a feedback survey also. So please take up the survey and send us by email. Thank you so much for joining. Vanakkam.
Thank you so much, Dr. Raghavendra. Thank you, Pavitra. And thank you to all the participants who've been with us through the lecture. And thank you very much. Thank you once again.
Thank you. Thank you.
Thank you. Thank you. Good night.